Meeting number 21 of the House of Commons Standing Committee on Health. Pursuant to the orders of reference of April 11th and April 20th, 2020, the committee is meeting for the purpose of receiving evidence concerning matters related to the government response to the COVID-19 pandemic. In order to facilitate the work of our interpreters and ensure an orderly meeting, I would like to outline a few words to follow. Firstly, interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. Please speak slowly and clearly and hold your microphone in front of your mouth as directed during the sound check. If you will be speaking in both official languages, please ensure that the interpretation is listed as the language you will speak before you start. For example, if you're going to speak English, please switch to the English feed, then speak, and this allows for better sound quality for the interpretation. Before speaking, please wait until I recognize you by name. When you are ready to speak, click on the microphone icon to activate your mic. And should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. A reminder that all comments by members and witnesses should be addressed through the chair. Should any technical challenges arise, please advise the chair or clerk immediately, and the technical team will work to resolve them. If necessary, we will suspend the meeting at those times to rectify the problem. Before we get started, I'd like to remind everyone that if they click on, for those operating on a computer, if you click on the upper right-hand corner of your screen, you'll see a speaker view versus a gallery view. If you click to gallery view, then you should be able to see everyone in the meeting. For those using iPads, it's a little icon on the upper left-hand corner. So I'd like now to welcome our witnesses. So from the Public Health Agency of Canada, we have Dr. Theresa Tam, Chief Public Health Officer, Ms. Kim Elmsley, Vice President, Infection Disease Prevention and Control Branch. From the Office of the Chief Science Advisor, we have Dr. Mona Niemer, the Chief Science Advisor. From the Canadian Institutes of Health Research, we have Dr. Michael Strong, President. And from the Canadian Society for Virology, we have Dr. Nathalie Granvaux, President. Welcome to all of our witnesses for being here. I appreciate, and the committee appreciates your time. And we will start with the Public Health Agency of Canada. I believe Dr. Tam, please go ahead. 10 minutes, please.
Good afternoon. Thank you, Chair and committee members, for the opportunity to come back to speak with you again today. So the emergence and rapid spread of SARS-CoV-2, which is the virus that causes COVID-19, has challenged global capacities in unprecedented ways. In Canada, there are now around 78,500 cases of COVID-19, including 5,857 deaths. Around 50% of cases have now recovered. Labs across Canada have tested over 1,337,000 people for the novel coronavirus to date, with about 5% of these testing positive overall. Collectively, provinces and territories are testing an average of over 27,000 people daily. As these numbers change quickly, we update it on the canada.ca/coronavirus website. While COVID-19 remains a serious global health threat, our collective efforts to slow down the spread of COVID-19 and bring the epidemic under control have flattened the curve in Canada. The slowed rate of transmission has reduced daily case counts, but there are still localized outbreaks and active transmission in different areas of the country, so we must remain vigilant. As the initial epidemic wave in Canada comes under control, rapidly detecting and suppressing any new surge in cases is the priority. And simply put, we must keep infection rates low while we accelerate the development of treatments and a safe and effective vaccine for COVID-19. Given the uncertainties of the path forward, we will need to exercise caution and learn as we go. Canada's response has and continues to rely on science, our evolving knowledge on how the virus spreads, and the deployment of effective public health measures. And we will adjust rapidly as needed to effectively reduce the spread of this virus as we reopen Canada's economic and social life. Canada's response to COVID-19 must continue as a collaborative response that supports and includes individuals, communities, different sectors, and governments. Our federal public health role can best be described as leadership through research and science, international collaboration, data and monitoring, and continuous risk assessment. Leadership in keeping Canadians informed about what we know, don't know, and how we are finding answers to the complex questions that a new infectious disease brings. And leadership by mobilizing capacities to rapidly address gaps wherever they exist and provide resources that strengthen the public health response wherever it is needed. A cornerstone of Canada's overall response today has been excellent collaboration among federal, provincial, and territorial governments. As we move forward, we will continue to work closely through the Federal, Provincial, Territorial Special Advisory Committee on COVID-19, which includes all the Chief Medical Officers of Health, as well as Correctional Services Canada and Indigenous Services Canada officials. At the moment, we are meeting several times per week. The Public Health Working Group on Isolated and Remote Communities, reporting to the Special Advisory Committee, has also been formed to collaborate on addressing the unique needs of remote and isolated communities and those of First Nations, Inuit, and Métis. I'll take a few minutes just to provide some updates on the key areas where the Public Health Agency of Canada is supporting the Government of Canada and our provincial and territorial partners in the response. Testing is a critical aspect of our COVID-19 response. Canada's testing strategy will continue to be adapted as science on the virus evolves, as more test options become available, and as the pandemic progresses. It is based on three central public health priorities of testing all suspected cases, aggressively tracing the contacts, and isolating infected people and quarantining contacts. Testing together with contact tracing are critical to setting up a ring fence around every case and breaking the chains of transmission. Canada's National Microbiology Laboratory, or NML, has played a critical role in this area. Within 5 days of the novel virus genetic sequence becoming available, scientists at the NML developed a molecular diagnostic test, and now more than 30 labs across Canada can perform confirmatory tests. And as commercial tests become available, the NML's validation and quality assessment programs rapidly ramped up to ensure that these tests deliver accurate results. The Special Advisory Committee on COVID-19 recently updated the National Laboratory Testing Guidance with a focus on broadening testing to anyone with symptoms, even those with mild symptoms. Considerations for testing asymptomatic individuals were also provided. The Government of Canada also recently announced the COVID-19 Immunity Task Force to coordinate population-based serology or antibody studies to determine the extent of COVID-19 infection in Canada. This will help determine the fraction of the population that have some immunity to the virus to inform effective public health responses going forward, including any vaccination programs. A robust testing approach is a key component of the reopening phases, and Canada is looking to implement a multi-pronged testing approach that encompasses a combination of lab-based PCR testing, point of care, and serology testing. A priority for all countries is the development of a vaccine for COVID-19. So the National Microbiology Lab is part of a national network using genome sequencing to understand how the virus works, how it is evolving, and why people experience such differences in the severity of illness. The NML's work on vaccine development builds on a track record that includes the successful development of an Ebola vaccine. We are pursuing 7 vaccine development technologies and collaborating with industry and academia to contribute to vaccine discovery. Another important area of focus for the Government of Canada has been securing critical personal protective equipment and medical equipment for frontline healthcare workers. We are doing this through collaborative bulk procurement with provinces and territories, building domestic production capacity, and identifying potential alternatives and ways to extend product life. The Public Health Agency also continues to work closely with provinces and territories to update infection prevention and control guidance based on the best available evidence for a variety of healthcare settings, including long-term care. Another important area of focus is keeping Canadians informed. So the Public Health Agency of Canada has been providing Canadians with timely information about how they can protect their health and our broader healthcare systems. This includes canada.ca/coronavirus website, a toll-free COVID-19 information line, and the Canada COVID-19 app, which to date has been downloaded by more than 540,000 times. So nationally, we have witnessed the impact of Canadians working together to slow COVID-19 epidemic growth through collective adherence to recommended public health measures, including physical distancing and hygiene measures. In moving forwards, all levels of government are committed to working together towards a shared evidence-based approach to the cautious lifting of public health measures with the primary objective to protect the health of Canadians and taking into consideration regional differences. There is a need to strike a critical balance between public health control measures that minimize health impacts and the social and economic consequences. For instance, border measures under the Quarantine Act to strengthen and restrict entry into Canada from abroad, including the US, remain in place. And these measures will be continually reassessed as new information becomes available. The Special Advisory Committee on COVID-19 recently provided recommendations and national public health guidance with shared objectives, principles, criteria, and indicators that serve as a foundation for lifting restrictive measures. We must also continue to strengthen public health capacity across the country in anticipation of potential future waves of COVID-19, which includes capacity for enhanced testing and to rapidly detect cases, investigate outbreaks, and find and manage contacts. The Government of Canada is also working closely with provinces and territories to expand testing capacity beyond the existing laboratories and strategies to mobilize human resources to support contact tracing. The impact of COVID-19 on the overall physical and mental health of Canadians has been significant. The direct health impacts have been devastating, with the most severe outcomes being suffered by seniors residing in long-term care and assisted living facilities. Our approach going forward must ensure that vulnerable or high-risk groups are better protected. And this includes the vulnerable because of age, underlying health conditions, remote location, closed living spaces, and temporary or unstable living spaces. We must also consider the unintended consequences due to restrictions in place, including increased domestic violence and social isolation, delayed care for acute and chronic health conditions, and problematic substance use. So, as public health restrictions are lifted, the aim is to be able to rapidly respond to any new cases or clusters to keep the epidemic suppressed. However, we must prepare for the possibility that public health restrictions may need to be reinstated if cases spike again. While we do not know what will happen with COVID-19 in a few months, public health has to prepare for the possibility of another wave coinciding with the annual influenza season. This and more challenges lie ahead of this unprecedented global health crisis. Public health authorities are aware, engaged, and fully committed to tackling these challenges head-on with the full weight of Canadian ingenuity, collaboration, and innovation. So thank you for your attention. I'll be pleased to answer any questions.
Tam? Thank you, Dr. Tam. We go now to the Office of the Chief Science Advisor, Dr. Niemer, please. 10 minutes, please. Dr. Niemer, you're muted still. And remember your microphone.
Alors, bon après-midi, Monsieur le Président.
Good afternoon, Chair.
Niemer, could you hold up your mic?
Yes. Is this better?
Okay.
Alors, bon après-midi.
Good afternoon, Chair. I want to thank you for giving me the opportunity to exchange with you today. I'd also like to thank my co-witnesses for their statements and for all their efforts during this pandemic. I was appointed, as you know, as Canada's Chief Science Advisor on September 26, 2017, to provide science advice to the Prime Minister and Cabinet. My office works to ensure scientific analyses that are considered in government decisions and coordinates expert advice to Cabinet. And I also provide recommendations on how government can better support quality scientific research. Furthermore, my office helps ensure that government science is fully available to the public. Lastly, I have a mandate to promote collaboration between federal scientists and academia both in Canada and abroad, and to raise public awareness of scientific issues. Since the beginning of the COVID-19 pandemic, I have had the opportunity to make contributions in all these areas, which I will summarize for you now. Starting in February 2020, I set up a number of expert groups and task forces. These experts are keeping us abreast of ongoing clinical and scientific challenges and best practices for the pandemic response in Canada. I've also been involved in the science coordination efforts within the federal government with respect to medical countermeasures and testing. I've worked with the broader science and research community to enhance coordination efforts. Among others, I helped set up the CanCOVID Network, a pan-Canadian research platform, to optimize collaboration during the COVID-19 crisis. More than 2,000 researchers are registered on the CanCOVID platform, which testifies to the extraordinary engagement of the Canadian scientific community in the response to the pandemic. And now I'm going to try to switch into English.
Additionally, I'm engaged in the international science advice response to COVID-19. Chief science advisors or equivalent from a dozen countries have been meeting weekly for the past 2 months. We discuss the dynamic developments and challenges of the pandemic and its evolving characteristics in different countries at different times. We share data and information on social and medical measures. These interactions provide important opportunities for coordinating research and science advice. An example of this international effort was the group's call to the global publishers to make COVID-19 scientific publications openly accessible to all, which the publishers quickly agreed to. This has meant that research results are now quickly disseminated and used to help manage the pandemic everywhere. This is an unprecedented development that's supporting scientific data sharing at a rate never witnessed before. Over the past few months, our knowledge of the new SARS-CoV-2 virus that causes COVID-19 has rapidly progressed, including efforts by our own Canadian researchers, but there are still many unknowns that affect disease prevention and management. I'll highlight a few of those with your permission. The first area is in terms of disease susceptibility. Not everyone in the population appears to have similar risk of infection, but how exposure to different levels of the virus leads to different individual response is unclear. As you can imagine, this has impact on prevention measures in different settings. The issue of infectivity still needs to be clarified. Infected individuals seem to be contagious 2 or 3 days prior to symptoms onset until around 7 days thereafter, possibly longer. This implies that significant transmission comes from asymptomatic individuals, and this creates an added challenge for early detection and the control of disease spread. With respect to disease outcome, we've all seen that older age and chronic preconditions such as cardiovascular disease, diabetes, or obesity have been associated with higher risk of poor COVID-19 outcome. However, the reasons remain unexplained. Our experts have pointed out to the need for harmonized quality data collection and sharing, which is important to sort out the confounding variables and more precisely guide disease management in the Canadian context. With respect to prevention and treatment, Dr. Tam has already alluded to the importance of the vaccine. In the absence of acquired immunity or effective vaccine, avoiding or minimizing exposure to the virus is the best prevention, and we know what this means. Vaccine development is underway, including in Canada, using a wide range of classical and novel approaches. With respect to treatments, several clinical trials are ongoing, including in Canada, to test the efficacy of existing drugs. However, so far, we have to say that the results are disappointing. It should be noted that there are presently very few broad-acting antiviral medicines, which is why the development of new antiviral drugs are being pursued in parallel to vaccine production efforts. And let's remember the successful management of hepatitis C and HIV with antiviral therapies, not vaccines. So I think that we have hopes on both fronts. With respect to diagnostics, Dr. Tam has already mentioned the use of the qPCR, which is the gold standard for testing the presence of the virus. However, this multi-step test is not very well suited for remote areas and for other situations that require faster or repeated screening, such as borders and primary care, which is why the development of complementary detection methods is ongoing. The Immunity Task Force, I have the privilege of sitting with Dr. Tam on it, and the work is undergoing. This is going to be an important work to determine the actual prevalence of exposure in Canada, but also to inform vaccine development. So as countries reopen their economies in the weeks and months ahead, the scientific community will continue to gather more data to better understand both the virus and the disease it causes. These efforts are instrumental for our ongoing preparedness to live with and overcome the virus. Around the globe, countries are also stepping up their efforts in key areas that include deploying robust and agile systems for virus testing and contact tracing, as well as understanding the level of the population that has been exposed to the virus. Another area is the standardization of data collection, constantly improving their quality and basically developing protocols for sharing and mining the data, including using AI-supported tools. This is, again, an effort that Canada is being part of. Of course, everyone around the world is stocking up on medical equipment, or at least trying, and therapeutics, and putting in place national strategies for local manufacturing of personal protective equipment, as well as COVID-19 diagnostics and medical countermeasures. More broadly, their countries are expanding research and development efforts and considering approaches to national health security across the entire medical supply chain. Last but not least, strengthening the health emergency preparedness, I think, is on everyone's mind, including at the level of the multidisciplinary science advisory function. So in conclusion, let me say that this pandemic is highlighting the critical value of research and the importance of science coordination across disciplines and sectors. It's also underscoring the need for national production capacity for health security. Right now, we're playing catch up, but it's hoped that current investments and efforts will result in a sustainable ecosystem for infectious disease research and development. The war against COVID-19 will be won through science. Let's ensure that Canada's excellence in science continues to be mobilized for the benefit of all Canadians. Thank you, and I look forward to our exchange.
Thank you, Dr. Niemer. We go now to the Canadian Institutes of Health Research. Dr. Michael Strong, President, please go ahead, 10 minutes.
Thank you, Mr. Chair, for having me before the committee once again to speak about the continued importance of research and Canadian Institutes of Health Research's, CIHR's, ongoing role in Canada's response to COVID-19. Before we begin, I want to reiterate my sincere appreciation and gratitude to all of the healthcare professionals, the frontline and essential workers who are tirelessly working to support the health, safety, and well-being of Canadians. I would also like to extend my sincere condolences to the members of the Canadian snowbirds for the tragedy of this past weekend. My wife Wendy and I had the opportunity to see the snowbirds in London on Mother's Day. It was a real treat. They are and always will be a symbol of pride that we as Canadians have in this great country. Our thoughts are with them at this time. As I am sure many of my colleagues here today will echo, I also wish to commend the incredible and continued efforts of the Canadian research community. Our researchers are among the very best in the world and continue to play a critical role in the global and domestic research response on COVID-19. And so I am pleased to be with you today to provide an update on the research initiatives that CIHR has recently implemented as part of Canada's efforts to address the pandemic. Before doing so, I wish to emphasize that CIHR's efforts to address the COVID-19 outbreak continue to be undertaken in very close collaboration with federal partners, including my colleagues that are appearing with me today, but also Health Canada, Innovation, Science and Economic Development, and the National Research Council, amongst many others. I also wish to highlight the recently established COVID-19 Immunity Task Force, of which Dr. Niemer referred. I am pleased to say that two of CIHR's scientific directors, Dr. Sharu Kasik and Dr. Carrie Bourassa, are lending their expertise on immunity infection and Indigenous health respectively to this important initiative. CIHR also continues to work hard, hand in hand, with international partners such as the WHO and the Global Research Collaboration for Infectious Disease Preparedness, otherwise known as GLOPID-R, to enable Canadian researchers to help in the global research efforts. Additionally, CIHR supports the calls made by the chief scientific advisors around the world, as again noted by Dr. Niemer, to ensure that research outputs such as data and publications are publicly available to support the ongoing global emergency response efforts. As I shared with you at my previous committee appearance, CIHR moved quickly in February to efficiently mobilize the research community through the launch of a rapid research response to COVID-19. In just a few weeks, CIHR was able to select, through a rigorous peer review process, 99 COVID-19 research projects focused on developing and testing medical, social, and policy countermeasures to address this public health crisis. Given the uncertain nature of vaccine development and therapeutics and the need for additional preventive measures, Canada's response to the COVID-19 pandemic also requires sustained research investment to ensure a rich pipeline of innovations. That is why on April 23rd, the Prime Minister announced an additional $1.1 billion in support of a national medical research strategy for COVID-19, including close to $115 million in funding for CIHR. This new investment builds on CIHR's initial rapid research response and will enable us to support researchers working on projects related to the development of vaccines, therapeutics, new diagnostics, and public health interventions to move to the next critical stage in their research. It will also help to secure Canadian participation in domestic and international clinical trials responsive to WHO priorities that will increase the understanding of the efficacy and effectiveness of vaccines, therapeutics, mental health supports, and clinical management approaches to COVID-19. As an instance, through this investment, we were able to provide Dr. Srinivas Murthy and team from UBC with an additional $3.5 million to support the Canadian Treatments for COVID-19 trial, otherwise known as CATCO, the Canadian arm of the WHO Solidarity Trial. This will enable Dr. Murthy and his team to expand the trial to include additional hospital sites and more study participants across Canada to study the effectiveness of different drug treatments for COVID-19. We are confident that this type of research will greatly contribute to our efforts to rapidly find effective treatments for the benefits of all Canadians. A portion of the investment will also be dedicated to working with Health Canada to improve ethics research review processes and structures. This will help accelerate the launch of promising multi-site, multi-jurisdictional research, including clinical trials across Canada. Further, these funds will also allow the Government of Canada, under the leadership of CIHR, to set up a Centre for Pandemic Preparedness and Health Emergencies Research that will lay the groundwork towards more nimble domestic and global pandemic research coordination. Finally, we have heard loud and clear from Canadians and healthcare providers that more support is needed to help understand and mitigate the mental health and substance use impacts of COVID-19 crisis. As such, CIHR, in partnership with the Public Health Agency of Canada and Health Canada, has established an expert advisory panel on mental health and substance use and will support research to facilitate the rapid synthesis and translation of evidence on effective virtual service delivery models for the benefits of all Canadians. We are pleased to share that the second phase of CIHR's rapid research response is currently underway, and we have received a staggering number of applications. This underscores the incredible and widespread mobilization of the Canadian research community in response to COVID-19. Applications for this second phase are currently under review, and funds will be provided to successful applicants in a few weeks. In the meantime, CIHR continues to coordinate and support the sharing and translation of ideas, data, and innovative solutions across all levels of government to enhance timely and effective responses to the COVID-19 crisis. Since we last met, CIHR has rolled out a number of virtual knowledge mobilization meetings to strengthen connections between researchers funded through the COVID-19 rapid response competition and the Government of Canada departments and agencies in order to accelerate research and knowledge translation. I want to reiterate that these investments in research provide the crucial high-level evidence needed to inform policies and clinical and public health responses to mitigate the rapid spread of COVID-19 and save lives of Canadians. The critical importance of the work generated by CIHR's research community brings me to my last point. As you may well be aware, CIHR has postponed this year's spring project grant competition. Given the growing interest in this decision expressed both publicly and within the scope of this very committee, I would like to take a moment to explain the reasons for this decision that was made in close consultation with our trusted partners. As a result of the COVID-19 outbreak and the redirection of government priorities to address the pandemic, CIHR placed a moratorium on all existing and any new strategic funding opportunities, with the exception of those related to COVID-19. At the time, CIHR could not be certain about the reliability of critical infrastructure required to deliver the project grant competition that requires the review of thousands of applications in a short period of time, just after all CIHR employees had been directed to work from home. And so we made the very difficult decision to ensure that these funds would be saved for the fall 2020 project grant competition. But at the same time, we also began exploring options to support researchers and trainees impacted both by this decision, as well as those impacted by the broader shutdown of research programs stemming from COVID-19. For instance, to support lead applicants whose work was impacted by the postponement of the spring competition, CIHR will provide prolonged financial support for existing grant holders for some and extend bridge grants for others. To support trainees, including students and postdoctoral fellows, the government recently announced new funding of $291 million to maintain income support for these individuals while the majority of academic research programs are closed. On May 15th, the Prime Minister announced an additional $450 million in funding to help Canada's academic research community during the COVID-19 pandemic. This funding will support universities and health research institutions to maintain essential research-related activities during the crisis and then ramp back up to full research operations once physical distancing measures are lifted. Further details on these supports can be found in the written brief that we provided to the committee in advance of this. To conclude, I would like to re-emphasize that CIHR recognizes the dual importance of supporting both Canada's response to COVID-19 as well as the broader research community that has been adversely impacted by this pandemic. Investments such as those recently announced are critical to sustaining Canada's research excellence, talent, and knowledge. To ensure that we are doing our utmost to support our researchers through the COVID-19 response and the post-pandemic economic recovery, CIHR continues to work closely with our federal partners, the research community, and health charities to explore additional ways to support our researchers in these difficult times. Again, thank you for inviting me here to provide an update on CIHR's continuing efforts to support COVID-19 research. I'm happy to answer any questions the committee may have.
Thank you, Dr. Strachan. We go now to the Canadian Society for Virology, Dr. Nathalie Granvaux, President. Dr. Granvaux, please go ahead. 10 minutes, please.
Thank you, Mr. Chair. Good afternoon, Mr. Chair, members of the...
just a reminder to hold your mic.
Members of the committee and fellow witnesses. First of all, let me thank you for the opportunity to appear before you today and speak as President of the Canadian Society for Virology. I am very proud to lead this young not-for-profit society that I co-founded in 2016 with Dr. Craig McCormick, who is a professor at Dalhousie University. CSV was originally funded to help Canadian virologists spread across the country, including world-renowned experts in basic, clinical, and epidemiological research to come together to exchange ideas and discover new opportunities for collaboration to meet the challenge of existing and emerging viral infections and realize their potential to lead in this research area. CSV now counts 220 members who study viruses that infect humans, animals, plants, and bacteria. CSV member represents universities, hospitals, and research institutes across the country. The society provides unique opportunities to bring the community together and foster exchanges, thus promoting collaborations to accelerate discoveries and translation of research findings to positive health outcomes for Canadians. Canadian biologists have made important contributions to the fundamental understanding of many viruses, which have led to the development of new strategies for monitoring, preventing, and solving global health challenges related to virus infections. For example, Ebola virus vaccine, anti-HIV drugs. As you can imagine, our community quickly plunged into the heart of the current global pandemic and is at the forefront of research to contribute to the understanding of SARS-CoV-2, the virus responsible for COVID-19, from a biological and epidemiological point of view, its diagnosis and treatment through antivirals or vaccines. The outbreak of SARS-CoV-2 was under the radar of members of CSV, including members of the executive, as soon as it appeared in China in December 2019. An immediate action of CSV was to contribute to the organization of support for healthcare workers, medical microbiologists, and virologists in China to help contain the outbreak, treat patients, and protect frontline workers who were facing shortage of protection equipment and supplies. Upon the leadership of CSV executive members, and together with Dalhousie University and members of the Canadian medical community, about $48,000 were raised through donations and were used to purchase and ship Tyvek suit to hospitals in Wuhan. Members of our community, including clinicians and microbiologists, were part of the team managing the first COVID-19 case in Toronto. Through collaboration with other CSV members, they quickly achieved laboratory culture of the virus. Other collaborative teams took alternative routes to culture the virus and very quickly test animal models, which are key to antivirals and vaccine developments. These tools are now spread through our community, who responded in an exceptional way by quickly redirecting their research to respond to the urgent need to better understand SARS-CoV-2, improve diagnosis, identify therapeutic strategy, and develop vaccines. The community effort is immense, and we want to acknowledge that this was only made possible thanks to the very quick response of the federal government and agencies. The major investment for COVID-19 research made through the CIHR, NSERC, SSHRC, CRCC, New Frontier and Research Fund, the International Development Research Center and Genome Canada has strongly supported the effort made by our community. It would not have been possible without this investment. This must, of course, be underlined, but should not make us forget the reason which has contributed to the lack of preparedness to face the current pandemic. Indeed, the lack of funding for investigator-initiated fundamental research over the years has strongly limited the diversity of research that could have given us an advantage over the virus. In fact, over the past decade, scientists have raised awareness against the class of viruses to which SARS-CoV-2 belongs. It was clearly established that the most probable naturally occurring threat that humans face is from a respiratory-borne arenavirus. That this class of microbes should have been a preparedness priority. I personally raised awareness about it to the CIHR Infection and Immunity Institute Advisory Board last year. The SARS epidemic in 2003, which had already affected Canada, should also have sent the signal for the necessity of preparedness. Scientists are in the best position to keep watch on emerging fields. In order for them to translate their observation into knowledge and tools to face emerging infectious disease, they need continuous and sustained funding for investigator-initiated research. Major investments were made at the time of the SARS epidemic, but once it ended, research funding in this area was limited and advances that had been made were stopped. If global research had continued, we could have had antivirals and or hint for quick development of vaccine candidates against SARS-CoV-2, a closely related virus. Accumulation of knowledge, including biology, interaction with the host, epidemiology, and ecology on diverse viruses would give us an advantage in the anticipated fight against emerging pathogens. As such, let's not repeat history and cut funding when this pandemic comes to an end. Let's also not make the mistake of focusing only on coronaviruses, but rather on a wide variety of viruses, as we do not know what the next threat will be. Importantly, SARS-CoV-2, like SARS, is a zoonotic virus, meaning it spread to humans from an animal. This pandemic is showcasing how viruses jumping from species can be a threat to humans, and further underscores the necessity of funding research on viruses of diverse origin, not only humans. Expertise in the manipulation and study of human-threatening viruses and development of antiviral and vaccine requires years of training. CSV members are currently training the next generation of virologists, and CSV is dedicated to provide support through career workshop and opportunity to network during sponsored symposium, awards, and lab exchange program. While CSV members are now focusing on COVID-19 related research, their research program on other viruses is on pause. It is essential to expand research capacity in order to ensure a broader scope of research on a variety of human and animal viruses. Importantly, to fight against viruses, virologists cannot work in silos. They need training in collaboration with researchers with expertise in immunology, vaccine and drug development, epidemiology, and ecology. Canada should support career and build capacity in various areas of virus-related research, such as fundamental research, epidemiology, and drug and vaccine development, by raising the profile of those career opportunities and creating supporting environments for training. The study and development of therapeutics and vaccine against emerging pathogens causing threats to humans, such as SARS-CoV-2, requires experiments that must be done in high-level containment level 3 facility. It is key that this infrastructure across Canada meet all the government laboratory biosafety guidelines at all times. This is essential for researchers to perform their required experimental work, to build knowledge of viruses, and respond quickly to a situation of threat. This was not the case in this current time, as several facilities were not certified and could not have been updated over time because of lack of funding. It is important that the federal government come in to secure funding for building capacity and maintenance of containment level 3 facility and animal facilities, which are essential for response to any emerging pathogen. The development of these laboratories should not only be in the form of infrastructure funding, but also in the form of operating fund. In closing, I want to leave you with the following take-home message. The spillover of emerging infectious diseases are continuing to increase, and the current pandemic will unfortunately certainly not be the last. Increased preparedness through funding of investigator-initiated research and infrastructure will cost far less than the public health and economic toll of another virus that we may have been able to identify and contain earlier. Lastly, it is essential for the CSV community that the required increase in basic virus research is not done at the expense of funding for the other fields, threats or disease. Virus-related research is part of an ecosystem that overall urgently needs more investment for fundamental investigator-initiated research. Finalement, quelques mots en français pour résumer que les chercheurs membres de la société.
And finally, a few words in French. Our researchers have quickly changed their research operations, and that wouldn't have been possible without substantial investments made by the federal government for COVID-19 research. And this funding is granted through many granting agencies such as the New Frontiers Fund, among other examples. But unfortunately, we are dealing with the consequences of chronic underfunding for the past several years. And we needed better investment. We would have been better prepared to handle emerging infectious diseases. Science is the only way to ensure safety in these situations. We must ensure that we continue to fund research. This pandemic, unfortunately, will not be the last one. We need to fund research and infrastructure. And in fact, that will cost us less at the end of the day than how much it will cost us when we're unprepared to deal with pandemics. We must increase funding for fundamental research. But that should not be done at the expense of funding other types of sciences or research about diseases and other possible threats. Virus research is part of an ecosystem of research, all of which is important and all of which deserves sufficient funding. Thank you very much for your time, and I'm happy to answer your questions.
Thank you for your attention, and I will be pleased to answer any question.
Thank you, Dr. Granville. We will now start our questioning. We will do 3 rounds of questioning. We'll start with our first round with Mr. General. Mr. General, please go ahead. 6 minutes.
Thank you, Mr. Chair, and through you, Mr. Chair, to Dr. Tam. On January 29th, you said that due to our legal duty to the WHO, you wouldn't recommend travel bans. There was a fear of being called out if we did anything different. Has the WHO's position on travel bans changed? I think she's
Dr.
on mute.
Tam, you're muted.
Hello, thank you for the question. So I think the international health regulations and the framework underneath which the WHO functions, or the WHO Secretariat, prior to this absolutely unprecedented event of our modern era, has really been predicated on the stopping the spread of
Sorry, Dr. Tam, I only have
risks.
6 minutes, so I'm just curious, has the WHO's position on travel bans changed?
I think that the WHO is recommending still that countries who are taking these additional measures like travel bans explain themselves, which is over 100 countries have had to explain why they have enacted such travel bans based on
that,
their goals.
Then, Dr. Tam, on March 16th, Canada implemented travel bans. Then are you still being concerned about being called out by the WHO, or are you confident in the decision that you made?
I think we're confident in having made the decision based on the evolving nature of the outbreak and the risk that it poses to Canadians. And we explained ourselves to the WHO in the time that is prescribed by the international health regulations. And we need to continue to evaluate it.
On that same date, then, you stated the ineffectiveness of wearing a mask to protect others, stating that this was based on science. On April 6th, you said a non-medical mask can reduce the chance of your respiratory droplets coming into contact with others or on landing on surfaces. Was this decision based on the WHO's recommendations or your own?
This was based on a review of the evidence through the Special Advisory Committee that I've just talked about with the other chief medical officers of health. And that's based on the evolving science, looking at the role of asymptomatic and pre-symptomatic transmission, and the evolving research that is being published. There was very, very little research being published prior to that. So we kept updating our advice based on the latest information. And I think
so then based on that then, Dr. Tam, a 2019 study at the WHO's recommendations on pandemics, including wearing masks, factored in science, but also other measures such as cost, benefit, feasibility, and resource implications. So would you agree that we had early knowledge of human-to-human transmission, meaning transmission droplets, yes or no?
I think we know that this coronavirus is transmitted by respiratory droplets, and primarily through the coughing or sneezing, but also through other means, through your mouth and your nose primarily. So that is the primary route of transmission. And we know the tried and true measures to reduce that risk, but we've also recommended non-medical masks, with preserving the medical ones for healthcare workers is an added layer of protection on top of the other public health measures.
So then why did you, as Canada, asks earlier?
As I said, as we reviewed the science, as the data was available, there was very little scientific information, some of which is through influenza studies, some of which is through laboratory studies, and some of it is through modeling studies. And we took the body of it. At that very week, there were a number of publications that we took into account. And as I said, a lot of it was also predicated on the publications on asymptomatic and pre-symptomatic transmission.
But Dr. Tam, you had just admitted that you would agree that there was knowledge of human-to-human transmission, meaning the transition of droplets, and masks protecting that. Moving on, only because we're short on time, on January 29th, you also said that no countries have put in travel bans, but Taiwan had banned travelers from Wuhan, China on January 23rd. Why did you omit this fact?
I'm not certain that I know exactly what travel bans Taiwan had enacted at the time, but of course things were undergoing rapid evolution with different countries doing different measures.
So based on Taiwan then, what lessons have you and the Public Health Agency specifically learned from Taiwan about how to effectively contain the spread of COVID-19?
Well, I think we've learned a lot over the last several months. And I still think that, obviously the paradigm in the past was that we need to contain the virus at source, and that
very specific to Taiwan,
extremely,
Dr. Tam. What have you learned specifically from Taiwan?
I think, like all other countries, we've learned the specific infection prevention control measures that is fundamental to public health, that we all know works in terms of, staying home if you're sick, washing your hands, covering your cough, all of those things. I think we're learning a lot more about how do we apply border measures and travel health advice. And we'll continue to look at what other countries are doing and what happens, particularly during this time as the economy or society is opening up in other countries. We need to sort of look at what happens to them and sort of learn from them as well.
Thank you, Mr. General. We go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead, 6 minutes.
Okay, Dr. Tam, I know hindsight's 20/20, but let's look to the future now and basing decisions on science and evidence. And so I want to ask you about the possibility of some sort of mandated use of masks in Canada. Now, there is plenty of evidence out there, it seems, that masks are of benefit, mostly in benefit in preventing transmission from somebody who has the disease, perhaps people who are still asymptomatic and don't know they have the disease, transmitting it to other people. So there's a whole bunch of studies. Let me quickly just run over some of them. Howard et al. In a study that hasn't yet been published, but looks like it'll be published in Proceedings of National Academy of Science. They looked at the evidence and they concluded the preponderance of evidence indicates that mask wearing reduces the transmission per contact by reducing transmission of infected droplets in both laboratory and clinical contexts. The Annals of Internal Medicine, a recent meta-analysis, 64 studies, showed that transmission was decreased by 50 to 80% in healthcare settings. A Leung study on other forms of coronavirus showed decreased transmission when people who are infected have masks. There was a kind of a well-publicized light scattering study in New England Journal of Medicine showing when you had a mask and when you didn't have a mask. There's also been a number of papers written on modeling, looking at what happens when you add masks, even if they're not a solution, but add this incremental benefit combined with other public health measures can significantly reduce the transmission of disease in the progression of the pandemic. Many countries in Southeast Asia that have done very well in their response to the pandemic require masks in public settings, places like Taiwan, Singapore, Thailand. And I think 90 countries globally have some kind of mandated use of masks. And now to top it off, there was a recent letter in the open letter in the United States signed by 100 prominent medical people to governors across the United States. And the people who wrote this letter were a lot of people from Harvard, 2 Nobel laureates, people from Cambridge, Oxford, Berkeley, all the big schools. And their conclusion was that requiring fabric mask use in public places could be among the most powerful tools to stop the community spread of COVID-19. So they too are calling for mandated use of masks. Now we're spending billions and billions of dollars in dealing with this. It's really important we don't screw up as we come out of our initial social isolation. How about some form of mandated use of masks?
So as I've just said, the Federal, Provincial, Territorial Special Advisory Committee, which includes the Chief Medical Officer of Health, have been reviewing the evidence, many of which you've just cited. And so they really wanted to ensure that there is flexibility according to their local context and local epidemiology. In provinces and territories where there hasn't been any community transmission, that's a bit different than, say, if you're in certain provinces where that has already occurred. So I think as we're exiting and beginning to cautiously and slowly relax some of the public health measures, we have updated our recommendation on the use of non-medical masks. And the way that is positioned right now, based on the evidence, but also based on Canadian epidemiology, is that when the local epidemiology and the rate of community transmission warranted, the wearing of non-medical masks or cloth facial coverings is recommended for when you can't physically distance from others, particularly, as you can imagine, public transport, grocery stores, retail places. And it is a matter of, you're protecting others. So I protect you and you protect me is part of that. And so as to what exactly happens in the individual jurisdictions like Toronto or Montreal, they are needing to have the flexibility to do that. But it is, as you said, an added layer of protection as long as everybody remembers. That doesn't necessarily neglect the need for physical distancing and the hygienic measures. It is certainly an added layer when you can't be assured that you can get that 2-meter physical distance from others.
Okay, so
Dr. Pulaski, could you raise your mic a bit, please?
So, Dr. Tam, I'm sure you would agree it would be wonderful if everybody in society did the right things, but that isn't the case. Would you be willing to consider the possibility of mandating the use of masks in places where there still is significant numbers of COVID-19 cases like Montreal and Toronto?
So again, I think that's a jurisdictional flexibility. And I think as you will see, Montreal is increasing that kind of recommendation. But also you have to support people to be able to meet those recommendations. So ensuring that those, for example, who can't, we need to make sure it is available to all segments of society as well. And that, I think Canadians played a very, very big role in controlling this epidemic. And we must bring them together and their collective action. So the wearing of masks is a massive social behavioral change. And I do believe that momentum is now there. And so I think engaging Canadians and maintaining that trust is very important. Whether you're mandating it, then I think it depends on what happens in your local jurisdiction as to whether that is warranted.
Thank you, Dr. Pulaski. We go now to Mr. Theriault. Mr. Theriault, please go ahead, 6 minutes.
Merci, Monsieur.
Thank you, Chair. My first question is for Dr. Tam. Dr. Tam, during your early appearances before the committee, China was the main hotspot of COVID-19. We discussed the threat level in the United States, our neighbors just to the south. We discussed their level of risk because of their healthcare issues. So many Americans don't have access to healthcare and so can't even be screened for COVID-19. And yesterday, during your press conferences, you said that reducing incoming travel allowed us to manage the first wave of COVID-19. So now, with hindsight, Dr. Tam, would you have recommended closing the Canada-US border earlier?
virus itself traveled across the world very fast. And so while the initial epicenter was China, we also picked up, of course, cases very soon. The Canadian surveillance system was able to pick up cases from Iran. But it was really the cases from Europe and the United States that had the greatest impact on the introduction to Canada. And as I said, at that time, because there were very few cases, we were doing incremental measures. Shutting down the longest land border in the world is a massive piece of decision that is one for decision makers. And in retrospect, and maybe looking forwards, the world might be a very different place in terms of whether this kind of measure is enacted. So we will learn from these lessons. But as you can imagine, you have to sort of look back and also think about, is this how we manage every epidemic? But for sure, this is something that is unprecedented, that, you know, every single country enacting travel bans practically is a huge deal.
My apologies. In fact, Dr. Tam, 1 million, almost 2 million Americans have COVID-19. They have a very high death toll. So my question, in fact, was very simple. With a bit of hindsight, would you have recommended closing the Canada-US border earlier? And when would you have closed it? When would you have recommended that the government do so?
With hindsight, at that time, there wasn't a lot of cases. And if you asked policymakers at the time whether they would have closed the border, I'm not going to, you know, sort of second guess what they may think now. But of course, with all the lessons learned and knowing that some restricting travel instantaneously is an option, with, of course, the society willing to take all the different consequences of that, I think going into the future, you may want to consider it.
Yes, but Dr. Tam, you have repeated the same answer. I don't know whether you're trying to shirk the question. My question is, in fact, very simple. So with hindsight, with what you know right now, with what you're telling us right now, would you have recommended that the Canada-US border be closed earlier? And when would you have closed it? When did you close it? And let's talk about June 21st. Will you recommend that the border be reopened? The Prime Minister said that he is making decisions based on science. Well, you're a scientist. I'm asking you a simple question. Please, can I have a simple answer?
What happens in June depends on the epidemiologic situation in the United States at the time. So we'll continue to evaluate it. But right now, I think the recommendation, and together with the Chief Medical Officers, no, we need to keep that border restricted as it is now. So going backwards, could you have done it faster? Possibly. I mean, I think that is definitely something that could have happened faster. But this virus was traveling in sort of invisible ways. One element may, you know, at the time, and so a lot of things happened very quickly around March 13th and then the 18th, and I think it was the 21st, when successively travel restrictions were placed very, very rapidly. As soon as I think we got the sense that this virus is actually in every country. We didn't just stop with Europe and the United States. We went with travel advice as well as the travel restrictions pretty essentially for the world, because you couldn't really tell where the virus is going to come from. And I think that in hindsight, yes, I think people could act faster, and maybe in the future, we will take different decisions, and that remains to be looked at in lessons learned.
15 seconds.
C'est important, c'est important.
The Prime Minister has told us time and time and time again that he makes decisions based on science. But here we are in committee And allow me to say, with all due respect, that science doesn't seem very clear. I think that scientists such as yourself should provide clear guidance. Now, I think that the Canada-US border was closed too late. Let's set that aside for a moment. In the future, though, we will need answers and we will need solutions. So I understand correctly, if I understand that you're saying we could have closed it earlier, we should have?
We're learning about this situation as we go. It is an absolutely unprecedented move. And I think going into the future, having learned what you just learned, actions may have been faster. Right now, though, I think some of the really key measures we've put in isn't necessarily just closing the border and reducing the numbers. It's also asking people to take the 14-day quarantine measures. So I think that is essentially the cornerstone of what we need to do going forwards as well.
Thank you, Monsieur Theriault. We go now to Mr. Davies. Mr. Davies, please go ahead, 6 minutes. Mr. Davies, you're muted. Maybe toggle your mute. Still muted. You look unmuted, but I can't hear you. Is there a mute button on your microphone? I can't hear you. Mr. Davies, are you still there? So let's suspend the meeting for a couple of minutes until we get Mr. Davies sorted out. Don, are you there? Oh, sorry, wait a minute. We now resume the meeting. Please go ahead, Mr. Davies, 6 minutes.
Thank you. I'll repeat my question. Dr. Tam, you spoke of the importance of data and keeping Canadians informed, and I share that commitment with you 100%. You spoke of the reason you altered your advice on masks because of your review of emerging evidence. Will you share the emerging evidence that you reviewed that caused you to change your recommendation on masks for this committee? Not right now. I just mean after. Will you send us that evidence that you relied on?
Yes, absolutely.
Thank you.
And again, the evidence is evolving as well.
Yes,
we know.
Dr. Tam, according to an April 27th article in the Toronto Star, the quote national modeling quote that you presented on April 9th was not an actual mathematical model. but rather a synopsis of scenarios produced by internal and external experts. In fact, by my assessment, PHAC has never published a single epidemiological model complete with transparent data, methodology, and assumptions to date. Norway, Germany, and Switzerland publish these often daily. Does PHAC not have such a model, or is it withholding it?
Yes, so I think what the approach we took was have panels of experts. I think there's at least over 30 modeling experts from across the country to look at more than one methodology. So it's not a single model, but they work pretty much constantly to update what the model parameters would be, one based on published information, but also based on the Canadian models around the country. So it is not a singular methodology, but one that takes into account many different ones. So that's...
I want to make sure I have evidence clear, Dr. Tam. Are you saying that the Public Health Agency of Canada does not create or have its own model that it itself is assessing, or is it simply evaluating and gathering other models created by external sources?
It would be both. For example, when I presented the short-term forecasting model, that is one of the methods, and that was presented. But that kind of model tells you what might happen in the very near future and depends on sort of case input. There are other models in terms of disease transmission models and dynamic models that we have in-house, but also takes into account many different inputs from scientists across Canada.
Will you deliver to the committee all models with data, methodology, and assumptions that are created by the Public Health Agency of Canada to this committee? Will you commit to do that?
Dr. Tam, can you remember to lift your mic up, please?
Yes, absolutely. And I do have Kim Elmsley, the VP.
Can you hear that now, Mr. Chair?
Modeling team, and she may want to supplement, but for sure, we can provide you with what we have. And I know that our modelers were wanting to provide their input into a peer-reviewed journal as well, and that they're trying to do.
Dr. Niemer, your website very recently indicated that it established 8 COVID-19 expert panels and task forces, and you mentioned those in your testimony. When were those task forces established, and how often have they met?
We established the first task forces, the science expert task forces was established, I believe, towards the end of February and had its first meeting on March 6th. Following that, that actually expert committee meets bi-weekly. It's been meeting, it's met today for the 16th time. After that, we established 2 subgroups that were focused on one on modeling and one on health systems.
Go ahead, Mr. Davis.
Mr. Chair, thank you. Thank you. I know that there's 8 task forces. When I go to the website, Dr. Niemer, there's no agendas, no minutes, no research studies that are published. Where can I find the information about what these task forces are doing?
We've provided the title of the focus of the task forces. However, we're not publishing the agendas or but we certainly have summaries of the meetings and what was discussed.
Well, I can't find any summaries of any meetings, Dr. Niemer. On your website, the first thing said in your website is that your office is committed to ensuring that government science is fully available to the public. Will you reveal to the public and this committee full disclosure of all minutes of meetings of all of the 8 task forces in line with your mandate?
I don't think there is any problem in providing the committee with the minutes of our test of our expert panels. I just want you to realize that.
Thank you, Mr. Davies. So that brings round one
Thank
to a
you,
close.
Dr. Tam.
Mr. Davies, thank you. We
I'm
go
sorry,
now
am I out
to
of time, Mr. Chair?
yes, thank you.
Thank you.
We go now to the second round. We start with Dr. Kitchen. Dr. Kitchen, please go ahead. 5 minutes.
Thank you very much, and thank you everybody for presenting today and your great presentations. It's great for us to hear all this information. Dr. Tam, it's been January since we last saw you, and thank you for coming back. And at that time in January, after a lot of prying and poking by me, I managed to get you to tell us that we could actually do 16,000 tests a day. Now, assuming that's roughly 108 days ago, that would amount to saying that we could have done 1,728,000 tests in that time frame. And since then, a lot of things have changed and a lot of testing has improved. Yet today, in your presentations, you're talking about only 1,200,000 tests being done. Why is that? Why are we not getting all these tests done?
Dr. Tam, you're muted.
So what I said was, on average, provinces and territories are conducting about 26 to 28,000 tests per day. We do know that there's capacity now to do, just in the public health lab system, about 60,000 tests a day.
Could you remember to hold your mic up, please, Doctor? Thank you.
Yes, but Dr. Tam, you said 16,000 back in January, and yet we have come up with more tests, and yet we not seem to be able to equate to significant tests. And I'm wanting to know, why is that being done? Is that because of a breakdown between federal and provincial?
I think we've been working very closely with the provinces and territories, but also a huge amount of work, of course, in getting supplies and whether it's swabs, reagents, and getting domestic manufacturing in gear right now as well. And so I think the capacity will continue to increase. As to whether the numbers of tests being done by each jurisdiction, part of it's related to where the epidemiology is at. British Columbia is doing a bit less now because their epidemics sort of wave is coming more under control.
I apologize for interrupting, but I do have some more testing or some more questions. So, Dr. Tam, in 2016, the Government of Canada entered into a multilateral information sharing agreement with the provinces and territories, which outlined the public health information that must be shared with the federal government during a global health crisis. However, this agreement is not legally binding. What steps is PHAC taking in conjunction with Health Canada to develop a mandatory information sharing system for all jurisdictions in Canada?
So right now, all information sharing is a collaborative one with provinces and territories. And so this is how the public health system is set up. So yes, we have to depend on the ability of the health system to provide that. And we are working right now also with StatsCan to try and see what we can do to improve on that in order to get the data at the national level and fill in some of the blanks in terms of the information that we have.
Thank you. Other jurisdictions have done a much better job of reporting demographic details. For example, numbers out of the New York City Health show that of all the cases that have led to death, nearly 98% of those have had an underlying health condition, underlying illnesses including diabetes, lung disease, cancer, immunodeficiencies, heart disease, hypertension, asthma, kidney disease, and GI and liver disease. China, in fact, as you're aware, their positive tests only come out with positive numbers if you test positive and you have pneumonia. So why does PHAC publish, doesn't PHAC publish more detailed demographic data as this is done in other jurisdictions?
We do have a detailed epidemiologic report on our website. And for example, in terms of hospitalized cases, close to 75% of them have the underlying health conditions. And also on the website will be the sort of analysis, for example, by age group, as well, by sex. That type of breakdown is available in the epidemiological report, and it is posted.
Dr. Tam, you mentioned in your report today talking about vulnerable age groups. And as you're aware, PHAC was developed in 2003 after the SARS epidemic. And after that, a lot of the studies talked about preparing people and for us for the future, for future pandemics. And in fact, Dr. Nemers said today, we've been playing catch up. And we've heard that from many other different presenters to the committee on similar things. For example, that research was stopped after the pandemic of SARS, and other issues such as our protocols were being forgotten. So my question to you is, it's been 17 years. PHAC was supposed to come up with protocols to make certain that we were prepared and our seniors were prepared for this situation. So what protocols and what steps were done by PHAC in the past 17 years to ensure that our seniors are not doing that? Because you're saying today we now have to prepare for that again. Why was that not done after SARS?
So,
Dr. Tam, microphone, please.
So the Public Health Agency has worked with the provinces quite extensively on pandemic preparedness and over many years. And I think in terms of the international assessments, we're like the Global Health Security Index, we're one of the top countries in preparedness. However, this is an absolutely unprecedented global crisis for which I think all of us will have to learn from. One of the key learnings is actually about long-term care facilities and how seniors are being or not being supported in our country. That is a big societal issue. And I think that is something that not just public health, healthcare, but society writ large, that we must come out of this having a much better system and approaches to look after our seniors. And then that would be, coming out of the first wave and preventing more tragic consequences for seniors going forwards. But I just have to emphasize, just as our researchers have said, this pandemic demonstrates the importance of public health and investment in public health, not just in the Public Health Agency, but in the public health system writ large in Canada, all the way from local to provincial to federal. And we are, relatively a small segment of the health system. And we are working very hard to prevent the negative impact on the healthcare system itself, and working with everybody in Canada to flatten that curve so you didn't get the horrific impacts on the hospitals and healthcare systems like you did in New York or in Italy. So the public health system must not be forgotten. I know that this crisis is massive, but I would like to think that in 4 or 5 years' time, the investments that we're seeing now in public health continues.
Thank you, Dr. Kitchen. We go now to Mr. Weber. Sorry, we go now to Dr. Jaczek. Dr. Jaczek, please go ahead, 6 minutes.
Thank you very much, Chair. And first of all, I do want to thank all the witnesses for coming today, sharing their thoughts with us. And in particular, I would like to thank Dr. Tam for all that she has done over the last several months. And really, it's been day in, day out. And I can't tell you how impressed I've been with your demeanor throughout this entire situation. So my first question is for you. Dr. Tam, you and I both know that contact tracing is an essential part of infection control, and this function is formed by local public health units across the country. It's very labor intensive, and it also requires quite a bit of skill in terms of investigative skills and diplomacy, because quite often people don't actually want to disclose where they might have been and who they've been with. And so it has been a real struggle here in York Region. I know our public health staff are working so hard regard. There's been a real effort to provide the surge capacity given the number of positive cases here. So now we're hearing about contact tracing apps and potentially their use in a situation as we're facing at the moment. So could you give us some of your thoughts about whether contact tracing apps could provide some relief to what is currently being done through our public health units?
Yes, thank you for the question. Of course, there is many people are working really hard on this crisis, and I just happen to represent the tip of the iceberg of the public health system. And you're right in that the public contact tracing is a fundamental public health competency, if you like. And local public health has augmented the capacity, and what we've offered to provinces is that if you don't have enough people to do contact tracing, please let us know. We have developed a roster of people. I know that they've massively increased training, for example, for students or medical students or retired health professionals to supplement their contact tracing capabilities, but we're also here to help. Including federal public servants who may be able to assist. So there are different rosters being offered to provinces and territories. The application, I actually think that if you look at some of the other countries, what you have to do is have a population that is ready to use the contact tracing as well. You actually have some of the applications, Canadians have to sign up to them, and you need significant numbers of participation in order for that to work. So I do think that it is a concept that provinces and territories are interested in, and we've been facilitating some of the discussion on some of the options. And so definitely more to come on that. Some, for example, Alberta had started using an application. They are trying to get more people to sign up to it, but thus far, I think in the Canadian context, they are still trying to get more people to be recruited. It is something that Canadians need to be engaged in terms of this conversation, so that they understand what this means. Privacy, of course, is also something of paramount importance as these applications are being used.
Thank you. What sort of percentage of coverage would you need, do you think, to make it effective to use an app like that? How many people would have to sign up to use it?
Well, it may depend on the exact setup of the application or the technology, because I think there are different solutions. But I actually would have to, get someone who's an expert in this to let you know. But I do know that depending on the level of infection in the community, the number of contacts you have to trace in order to suppress the chains of transmission can vary. It can be between 50 to 60% of contacts have to trace in order for that transmission chain to be stopped. So you can imagine that it takes a significant number of people to have signed up to this for contacts to even be notified.
Thank you. Now, we all know that we make decisions on what we know when we make them. And based on that knowledge, we make our decisions, which leads us to data availability. And we've heard a number of witnesses who've come before the committee to suggest that even though you've talked about the great collaboration with provinces and territories, there is a real lack of consistency in public health data that is publicly available and in real time. There's been question about why wasn't the case definition the same for every province? Why wasn't every self-assessment tool the same? So in light of this and some of the comments you've heard this afternoon, would you say that there really is a need for the creation of a pan-Canadian public health surveillance system?
So first of all, the data gaps is challenging, I would say. And part of it is a capacity issue, potentially, at different levels of the public health system. We do have a pan-Canadian public health network that we actually have many national or federal, provincial, territorial surveillance systems as it is. But we do need to improve on the, we actually have national case definitions, but it's up to the provinces and territories to look at that, report to us according to the case definitions. But sometimes that does vary, and we do have certain data gaps that we must address. So this is a critical aspect going forwards, including, I think a lot of people have called for disaggregation of data, for example, according to race and Indigenous status, and that I know some jurisdictions are working on that, but that is still a gap for sure.
Thank you, Dr. Jaczek. We go now to Mr. Weber, and I have to correct myself. For the last two question slots, I said were 6 minutes. That is incorrect. We revert now to our proper time slots of 5 minutes for Mr. Weber and Mr. Kellery following. So, Mr. Weber, please go ahead. 5 minutes.
All right. Thank you, Mr. Chair, and thank you to all the presenters today for your opening remarks. I, too, Dr. Tam, want to begin by saying that I have great respect for the work that you have done, and that we are appreciative of the time and energy that you and your team have put forth in these past few months. And I also know that your public availability on a regular basis only adds to your workload, but it certainly is appreciated. In your opening remarks, Dr. Tam, you mentioned about moving forward, and that all levels of government are committed to working together toward a shared evidence-based approach to the cautious lifting of public health measures, with the primary objective to protect the health of Canadians and taking into consideration regional differences. So I want to bring up elective surgeries throughout this country. Now, we know that elective surgeries across Canada were put on hold as we braced for a wave of this COVID-19 cases in hospitals across the country. However, Dr. Tam, we are sacrificing the health and well-being of many thousands of Canadians who have other equally significant health concerns. Canadians expect this federal government to take a leadership position on this issue, as it is their advice that provinces are relying on for guidance during this pandemic. So last week, Dr. Tam, here in committee, Dr. Paul Dorian testified that these cancellations are costing lives. He said he personally knew of 4 deaths in just 1 week in a hospital in the Toronto area, if I understood that correctly. Dr. Tam, when do you see the cautious lifting of elective surgeries throughout this country?
So, given the regional differences, what we did together with a special advisory committee was to establish the criteria upon which jurisdictions can then look at easing the public health measures. All chief medical officers were very cognizant of the unintended consequences of public health measures, which some of them are definitely negative, although there are some that are positive. And so we also provided guidance on some of the initial areas that needs to be eased. And one of them is non-urgent, but non-urgent medical services. So this is in the very initial tranche of areas that jurisdictions will be looking at. And I think some of them have already began resuming some of this, but of course, that is within the provincial territorial mandates.
Yes, yeah. Now these unintentional consequences, Dr. Tam, can you tell us how many elective surgeries were postponed? Have you got those numbers at all by chance? Or how many deaths, for example, how many deaths in Canada due to the postponement of these elective surgeries due to COVID? Two questions in there.
Yes. So this is an area that I've really stressed to Statistics Canada and the Canadian Institute for Health Information. And you may have seen that Statistics Canada has released the initial quarter of excess mortality in their report. Of course, in the first quarter, the epidemic was only just starting in Canada. So it's the data in April from Stats Canada that will give us some inkling of the excess mortality statistics. In addition, we did discuss at the Special Advisory Committee some of the key data that we would like to seek from some of these organizations in order for us to look at the some of the key unintended consequences. So that work is underway.
Okay, thank you. Just on another line here, as you may be aware, this Committee of Health has been meeting twice a week during this pandemic. And the Minister of Health has said that our work in committee here is important. Now, because this is the first time, Dr. Tam, that you have appeared before the Health Committee since the pandemic was declared, I'd like to know if you are paying attention to the testimony here, as it is often at odds with government actions and priorities. So can you, Dr. Tam, just let us know specifically what testimony you've heard at our committee here and what impact that has had on your decisions?
So, you know, a lot of things have happened, and I just want to maybe just look back at the records of when I last appeared. I think some of them were estimates, but I think it was March the 11th was the last time, and much has happened. And we do have a team at the agency that keeps us apprised of the outcomes and activities of this committee. And it is a really important committee because the crisis is extremely complex, and you actually have to look at many different dimensions of this, and fundamentally the perspectives of many different sectors and Canadians as well. And so I think is absolutely critical that these kind of discussions occur and that we learn from, you know, some of the deliberations. And so I think, of course, many of them are from healthcare workers from the front line. And in terms of the kind of support they need, of course, from the Public Health Agency perspective, a lot of what we do is more guidance, but also the huge amount of work done by many departments in getting personal protective equipment, for example, is coming out of some of your deliberations on how we better protect the front line. It's only but some of the deliberations. And of course, as we've already said, the significant impact on the long-term care homes and seniors is extremely important for Canadian society to have a good discussion on how do we do that better moving forwards.
Thank you, Mr. Weber. Mr. Kellaway, over to you. 5 minutes, please.
Thank you, Mr. Chair. Before beginning my line of questioning, I just want to thank each of the witnesses for their tireless research efforts and dedication to the fight against COVID-19. Hearing you speak today only confirms to me that Team Canada's got the right folks on the job, and we'll get through this together. I have 3 questions, and we'll see if we can get through the 3. My first question is for Dr. Niemeyer. So, Dr. Niemeyer, I understand that the COVID-19 Immunity Task Force intends to oversee and support serological testing in Canada over the next 2 years to track the extent of the virus in the general population and in specific groups at greater risk of being infected. Can you describe the task force role in overseeing and supporting this testing in Canada? And what role will the provinces, the research institutions, and others play in the work of this task force?
Yes, thank you very much. This is a very important task force, and the work will be done in collaboration with the provinces, the academic hospitals, and a number of existing networks in Canada, such as, for example, the Network for Study of Aging, and so on. The idea of having the task force is really to coordinate the collection of the data, and I'm very impressed that we're talking a lot about the data. So I think it's to make sure that all the right data is collected, harmonizing basically the approaches, and making sure that everybody's using the right tools, the right tests. That is because there are a lot of tests that give more false negative, have less sensitivity, and so on. So it's a coordinating function, but the work will be carried out evidently in locally in the research hospitals and as well in collaboration with the Public Health Agency locally, who have representation on the task force.
Doctor, will vulnerable population groups be tested and those in rural Canada as well?
Yes, absolutely. I'm happy to share perhaps the development that there will be a indigenous circle actually to work with the indigenous communities. There are efforts already to look at what's happening in children, but also longitudinal studies in healthcare workers to see when they have developed immunity and until when it stays on and so on. There are a number of these that are ongoing. I can't remember them all, but we've got already started.
Thank you very much. Dr. Strong, my next question is for you. And while there are a number of groups in Canada conducting research around a vaccine for COVID-19, Dalhousie University in my province of Nova Scotia has been the first to be approved for clinical trial. Can you tell me how CIHR will support Dalhousie University researchers through their development?
Yes, thank you very much for that question. There's two sort of aspects on that. The first one is that we do, through the original initiative of the rapid response, provide funding through to researchers at Dalhousie who are participating in this. But the second is that we've been very involved working with our colleagues at ICED, NRC, Health Canada, and PHAC as well, to help in the design of the studies that are going to be needed to know about the effectiveness of this. We know that those studies will first be driven through Dalhousie for that. And then at the current moment, we're in the process of really adjudicating a massive number of grants in which we expect we will see that roll up coming into play.
Great. How much time left do I have, Mr. Chair?
You have 2 minutes.
Okay, wonderful. My next question is for the Society of Virology. Dr. Granvaux, I read in the CBC Online last week that the novel coronavirus is mutating. Can you tell us what that means for fighting the virus and for tracking it? Is the virus mutation going to help or hinder international efforts in dealing with COVID-19?
Sorry about that.
Okay.
So the virus is indeed mutating, but the good news about SARS-CoV-2 is that it's mutating far less than influenza, for example. So the rate of mutation is pretty low. That doesn't mean there will not be consequences, because you only need one mutation to have a consequence. So for now, the mutation that have been identified, we don't know what is their consequences. We know there is two major strains. One that has that came from Europe, a mutation that started in Europe, and the other is the original strain coming from China. But it could impact the transmissibility, it could impact the effectiveness of a vaccine if we develop it. But there is no way to predict that in advance. So it's a possibility, it's low, but it's there.
Thank you, Mr. Kellaway.
Thank you.
Turns out it was more like 1.5 minutes than 2 minutes.
It's all good.
So we go now to Mr. Theriault. Mr. Theriault, go ahead. 2.5 minutes, please.
Yes. 2.5 minutes. I'm going to ask a question of Dr. Granvaux, a short question, because I want to allow her the time to express herself. They say that we're managing time well, but we don't have a vaccine. We don't have antivirals. We are starting a certain type of testing. We want to be able to trace contacts, but there have been delays. You indicated in your presentation that we are dealing with something that we don't really know what it is. We're fighting something which is unknown. So at this stage, what would be the lessons that could be drawn from this epidemic so that in future epidemics we would not make the same mistakes? Well, that's a very interesting question. I think that the only way to fight an enemy that we don't know what it is to be able to continue to allow researchers to research as broadly as possible. Because when you narrow their research, you're forcing them to go in one direction. But when you do allow them to explore more broadly, when you don't know what the future will hold, it could be better. And I also believe that you have to listen to the lessons learned. The different research institutes have learned things and have suggested that this threat existed earlier on, but they weren't listened to, not just in Canada, but overall in other countries. So we have to be more aware of what is out there and deal directly with it. Are you optimistic about the possibility of our having being able to develop a vaccine? Or do you think that maybe we will have antivirals discovered that will conquer the virus? There's a great deal of effort that's being expended on this, but we've not yet been able to get a vaccine. Hopefully, we will, but we cannot say when yet. I do personal research in the area of antivirals, and I can say that a vaccine always allows, it will mean that you always have to know what the next virus that you're going to have to face will be. But with antivirals and in molecular research, we can help them move along. If you can deal with symptoms with antivirals, if you can diminish the effect on the patient, I think that we will be able to move into the future facing vaccines with more serenity.
Merci.
We go now to Mr. Davies. Mr. Davies, go ahead.
Thank you.
Thank you, Dr. Tam. As you know, long-term care homes account for over 80% of the deaths from COVID-19 in Canada. Why did the Public Health Agency of Canada wait until April 13 to release interim guidance for infection prevention and control of COVID-19 in long-term care homes?
Yes, so there's the fundamentals of infection prevention control has always been there, and there's existing precautions that's already well published on managing viruses such as coronavirus, and that spreads through the respiratory droplet route. So all of that was available. But with the experience that was fundamental at the long-term care homes, which is not a specific guidance hadn't existed at that time. It was a broader foundational guidance. So we took the opportunity together with experts that have managed these situations to develop a guidance because it was going to be very helpful. And we also incorporated new evidence on the pre-symptomatic, asymptomatic transmission, which resulted in a recommendation of a masking and personal protective equipment for the whole shift, which was also new at the time. So the timing was to coincide with the evidence, evolving evidence as well.
Thank you. Now, Dr. Tam, in 2006, you co-authored a report on pandemic preparedness in Canada titled, timely enough, The Canadian Pandemic Influenza Plan for the Health Sector. Now, that document called for the Canadian government to make plans to ensure a consistent 16-week supply, that's 2 pandemic waves of personal protective equipment, such as the N95 respirator masks, gowns, etc., specifically because your report acknowledged there would be shortages of the materials and supplies during the pandemic period. Yet, according to PHAC whistleblowers, on February 12th, 2020, the National Emergency Stockpile included only 94,000 surgical masks, 100,000 N95 respirator masks, 400,000 face shields, etc., the equivalent of 1 week's worth of use in Ontario alone. As Chief Public Health Officer of Canada, what accounts for this failure to ensure that Canada had a consistent 16-week supply of personal protective equipment prior to the outbreak of COVID-19, as you yourself identified and recommended in 2006?
Dr. Tam, remember your microphone, please.
Yes, so absolutely, that is a Canadian pandemic influenza plan. And the Canadian health system, as you know, is not just the federal, but provincial, territorial systems as well. And each of the provinces have their own stockpile. So this is a recommendation for the country. The National Emergency Stockpile
With respect,
system,
it was for the Canadian government, Dr. Tam. You were recommending that the Canadian government have 16 weeks supply.
Don, no more questions, please. Please answer, if you will.
Yes, so I think, again, the National Emergency Stockpile system went into full gear into getting all the supplies that we need, and there was a global shortage. So I think going forwards, I would like to see that there's support for the National Emergency Stockpile system and the public health system writ large, given what we know about global supply. The Canadian public and the government can decide how much of this they would like us to actually stockpile going forwards. We're going to learn a lot, as we've just said.
Thank you, Mr. Davies. Now that brings round 2 to a close. We'll start round 3 at this point. Ms. Jansen, please start. 5 minutes, please.
Yes, thank you, Mr. Speaker. I'd like to direct my questions to Dr. Tam. On January 31st, Marnie Johnstone, Executive Director at PHAC, sent an email stating, we have some stock in National Emergency Stockpile, including stuff that's expiring in February and March, that we're able to donate without compromising Canadian supply. We now know that Marnie Johnstone's assessment of our PPE needs in Canada was dead wrong. What modeling data was she using to suggest that the donation would not compromise Canadian supply?
Well, I think at the time, the concept was, and the global concept was containment at source, which means as much as possible control the outbreak at source in China. So that was critical. And so the federal government did make a donation at the time.
So I just was wondering, what sort of data was she using to decide that there'd be no compromise to the Canadian supply?
I'm not sure I can speak to that, but all I can say is that that particular set of PPE was probably not going to be usable, as it were, based on the standards at the time in a very short time frame.
According to the email, it makes it sound like we had stuff that was expiring and we had plenty enough besides that. So, but anyways, let's move on. We can see in her email, she was in a rush to get those supplies to the Red Cross in time for a repatriation plane that was departing for China. She mentions about formal signatures that we could get them later. Don't worry about it. Is it possible that her rush to make the flight played a role in such a serious error?
Well, I don't think that was necessarily the case. But I think, as we said, expired stock and near expired stock normally would not have been used in the Canadian context.
But we did actually need that expired stock already here in Canada, unfortunately. But anyways, okay.
So going forwards, though, we're doing everything, including Health Canada, providing instructions on expired stock, and even re-sterilizing certain equipment as well. So we're pulling out all stops on that.
Now I'm just going to go on to January 25th. The WHO assessed the risk of COVID-19 event to be moderate at the global level, while PHAC assessed the risk for Canada as low. And that was actually the same day the first case of COVID-19 was identified in Ontario. February 2nd, WHO changed that threat level to high. On February 17th, the Cabinet passed an order in Council that read, and I'm quoting here, the introduction or spread of COVID-19 would pose an imminent and severe risk to public health in Canada. Yet, after that date, you continued to insist that the risk to Canada was low. Now, why did you disregard the official conclusions that there was an imminent and severe risk? And what do you think are the consequences of leading Canadians to believe that the risk was low?
Well, I think we right from the start, when we knew about the cluster in Wuhan, we have been escalating the Canadian preparedness because there was an uncertainty as to what was going to happen.
But why was there a difference between what you said? What was the difference between what you said and what everybody else was saying?
So the risk assessment at the time was, in terms of the domestic transmission, was low because we actually didn't have many cases in Canada at the time. So
and
that
yet
was not
cabinet
the
called it
global.
imminent and severe.
Point of order, Mr. Speaker. She asked the question, and let this witness answer the question, please.
So I think we were all aware of the potential introduction risk, but at that time, if you were in Canada, given that we didn't have community transmission to any extent, the risk, if you were in Canada, was going to be low. We also had a much more sort of granular assessment of risk as well, which means that—
Sorry, my apologies. I'm just wondering, why would Cabinet have called it imminent and severe and you did not? That's the question that I have. I don't understand the difference.
I think throughout, I've actually asked that this is a serious situation and we need to prepare, and we need, I got the whole system going in the public health system ever since we heard about the virus, and we need to prepare with the potential that this is going to be an extremely severe situation. At that moment in time, the domestic transmission was not, that was the risk we were trying to assess.
Okay.
But it would be different if you were going to Wuhan or if you were going to some other place.
Okay.
So that's different levels of risk assessment.
Up until early April, you stated that asymptomatic persons shouldn't wear a mask because it didn't work or was harmful. And then on April 6th, you changed your mind and said a mask was good for additional protection. You insisted that Canadians, time and again, COVID-19 didn't transfer from human to human, but Dr. Maria Van Kerkhove of the WHO admitted in April 13 that, and I'm quoting, right from the start, from the first notification they received on the 31st of December, given that this was a cluster of pneumonia, immediately thought, given that it's a respiratory pathogen, that of course there'd be human-to-human transfer. So Canadians are confused. Why have we been told that science has the answers? Canadians are looking to you as a top science official in the country, and they don't understand why your message changed so much. Why do you lead Canadians so far from the known scientific facts that masks do work?
So there was a lot of different points made. Human-human transmission was always a possibility. At the beginning, we just didn't know whether it was a zoonotic event, but it was soon apparent that there was human-to-human transmission.
Right, because the WHO obviously felt that.
Thank you, Ms. Jansen. Your time is up, but I'll let the witness respond to your question. Thank you.
So in terms of mask use, I've just said, the recommendations are done collaboratively with the other chief medical officers and the special advisory committee, and we review the evolving evidence. I think it is very reasonable, and I'm sure all the research scientists will agree that we have to incorporate information as we go along. And so we incorporated the studies, which were actually not that many, but we incorporated them on asymptomatic and pre-symptomatic transmission, but also the potential for the added layer of protection. And so I think it's reasonable to bring Canadians along to the latest recommendation, and recommendations will evolve again as we know more.
Thank you. Thank you, Ms. Jansen. We go now to Ms. Sadhu. Ms. Sadhu, please go ahead, 5 minutes.
Thank you, Chair. Thank you, all the witnesses. Dr. Tam and your team, we do appreciate the work you're doing. Thank you very much. So my first question is to Dr. Tam. The province of British Columbia has implemented an online serology survey to seek more information on how the disease has impacted citizens. What value is there in having a survey like this? Do you think more provinces should consider to implement that?
Well, I think that citizen engagement is actually very important because of their key role in stopping transmission. And so I think that we look towards the study in British Columbia with great interest. I think we need to understand more of what the Canadian experience has been. I'll just also point out, and I'm not sure whether CIHR might, Dr. Strong, wish to comment, but there's also in line with the biomedical research, there's actually social science and other research as well that is ongoing to look at Canadian perspectives. And there's research looking at, in fact, what Canadians think about contact tracing, for example.
Thank you. My next question is to Ms. Almsar. We previously heard from Canadian Federation of Nurses Union, who had concern about PHAC's guidance for PPE in healthcare setting. Can you explain to us what work you are doing with the healthcare professionals to inform these national guidelines and standard? What kind of evidence do you and your team use to inform these national guidelines?
Thank you very much for the question. Can you hear me?
Yes.
Okay, thank you. So to start with, whenever we are developing guidance, we start with the review of what the scientific evidence tells us. Then we use a very wide network of stakeholders to help us interpret the evidence, identify gaps in that knowledge, and to use that to develop guidance. We also work with groups such as the Canadian Federation of Nurses Unions and other unions because they do bring important perspectives to the table from their knowledge of what's happening on the ground. And so whilst there can be debates on the interpretation of science, what we do always is bring those perspectives from workers into the conversation. We take their questions and concerns and refer them back to the experts. It's a bit of an iterative process to arrive at finally the set of guidelines that we believe at the Public Health Agency, based on our assessment, are the most important guidelines and the most reliable and accurate guidelines at that point in time. The reason they're interim is because we're always looking at evidence and we are always analyzing evidence, and that may update or change our guidance. One of the other things we're doing to stay in contact with the nurses unions and other important unions across the country is that we've set aside a weekly meeting where we invite those stakeholders to come and share their experiences. I use those opportunities to give them an update on the guidance that we're developing and on other things that are happening at the agency. They very generously use that time to indicate where they have concerns and where they would like to see the Public Health Agency of Canada doing more work. So it's a really important dialogue that we are maintaining. People don't always agree, but what's important is that we're listening carefully to each other's perspectives. And in fact, the perspectives that in this case, the Canadian Federation of Nurses Unions brought to us during this process did lead us to clarify areas in the guidance that perhaps were confusing and to adjust areas where we felt, based on their interventions, that we could make important changes.
Thank you. Mr. Chair, do I have more time?
30 seconds.
Okay, so can you explain the guidelines for the home care settings as well?
So in developing guidelines for home care, we use the same process in the sense that, we're bringing the experts together, using the evidence, and then bringing the communities together that work in these areas to ensure that the guidance is highly relevant to them and that they can use it in practice. What we've learned is that, oftentimes technical guidance needs to be used in different formats so that people can apply it easily on the ground. So in the context of home care, really important that those important workers are well supported as they do their jobs in different contexts. And our guidance is always going to be based on what we've learned, what we know, and how we can best adapt it to meet the needs of those workers in as clear and relevant a fashion as possible.
Thank you, Ms. Sidhu. We go now to Mr. General. Mr. General, please go ahead, 5 minutes.
Thank you, Mr. Chair. And Mr. Chair, through you, before I get to my questions, just on some of the timeline to Dr. Tam. On January 26th is when the National Microbiology Laboratory received its first case, and lots of the
Alex,
decisions that were.
I know you're very late, and
Mr. Sidhu, could she mute herself? And thank you. Going back to January 26th is when the first case came to Canada. there just it questions the role and the sense of urgency that the public health agency plays in this country, seeing that some of the decisions that we've seen up to this point not made until late February, March. So with that being said, I want to ask some of my questions, and particularly when it comes to the PPE supplies. We sent 16 tons of PPE to China in February. Has that allotment sent to China been fully replaced by China?
I don't know exactly how to answer that question. I know that there's various donations. I have not been particularly involved in the exact logistics, and we can get back.
That 16 tons. That would be great to know if we're even close to that number of getting that 16 tons back. A 2011 report said that the Public Health Agency had 11 NESS warehouses spread out across Canada. That same 2011 report said that there were 1,300 pre-positioned sites containing supplies. Sally Thornton, a vice president under your supervision with the Public Health Agency and in charge of the NESS, said that there were only 1,000 of those sites in 2012. How many of those sites existed at the start of this pandemic?
Dr. Tam, microphone, please.
So Sally Thornton is the VP that's most close to the specifics of NESS. So I think definitely take her numbers. I know that a lot of those preposition sites were like cots and blankets, essentially. It was not actually PPE or any of the medical countermeasures. So I think
would it be possible to get that that number from you or Sally, Dr. Tam? Just how many sites were that we had remaining from those 1,000 in 2012?
Yes, we can get back to you. But again, they were, small stashes of sort of post Cold War kind of, I think, equipment. So I think
it would just be helpful to piece together the whole story here, if that's all right. Just because I'm short on time, I want to move quickly to, in documents obtained by this committee, and a briefing note dated February 10th mentions that the Public Health Agency are conducting a PPE survey on provinces and territory supplies for areas of vulnerability to ensure sufficient supply. What date did that survey begin?
I'll have to get back to you. I know that the survey continues in a very diligent way, but we'll have to get back to you on the
Was it before or after February 4th? Would you know?
I do not know. We'll have to get back to you.
Okay, I'd previously requested a copy of that survey from Sally Thornton, so hopefully between the two of you, we'll be able to get a copy of that survey. She had agreed to provide the survey and looking to see the results of that survey. Do you think Dr. Bruce Aylward attending our committee would benefit the committee's ability to review the government's response to COVID-19?
I think the committee should feel free to invite your witnesses. Dr. Aylward obviously works for the WHO, and he was, critical component of the WHO response. He's not part of the agency. Doesn't work in Canada. So I think that, of course, the WHO, I'm sure, gets invited to committees such as this. So I think please invite the witnesses that you think would be helpful to you.
Just a point of clarification for the witness, Mr. Chair. Dr. Aylward has been invited to this committee. He's actually turned down the invitation a number of times. We actually had to put forward an official summons to have him appear. That would lead me to assume that there hasn't been a sense of seriousness taken by the WHO to actually come to this committee. I would hope that if any sort of pressure that Dr. Tam or the Minister Hajdu could put on Dr. Aylward or members from the WHO to take this committee seriously would certainly be appreciated, I think, by all members of this committee, because we all did vote unanimously as in favor of having him come, and we also voted unanimously in favor of the summons. So I would hope in the next conversations, in any conversations, encouraging Dr. Aylward to come forward to this committee.
Thank you, Mr. General. We go now to Mr. Van Bynen. Mr. Van Bynen, go ahead. 5 minutes, please.
Thank you, Mr. Chair. And thank you, Dr. Tam, for joining us today. And thank you so much for your incredible dedication to Canadians through this pandemic, and particularly when you tend to get barraged in second guessing some decisions that were made on the basis of the knowledge that was in our hands at the time. I appreciate you coming back to the committee to update us, and you've provided for a number of updates on modeling. Do you have a new update that you could share and provide to the committee today? And I promise you, I will listen to your answer because I genuinely want to hear an answer.
Well, I think the most important updates people, decision makers or Canadians want to hear is where we are at and whether things are getting better. So I think all of our indications that is the epidemic is definitely slowing down. So one of the things that we looked at was, of course, the rate of rising cases or dropping cases. And the case count, I think over the last 7 days compared to the previous 7 days has dropped by about 13%. And when we looked at what we call the doubling time, the epidemic showed the exponential growth at the beginning. So the doubling time was about 3 days, which is very fast. And now it's almost an irrelevant indicator because it's now over 30 to 60 days. So that tells you that the rate of increase or doubling is definitely slowing down. There is one indicator that people now that they've so everybody's interested in is what we call the effective reproduction number, which is to look at whether one Canadian transmits to less than one Canadian, in which case the chain of transmission will break. This number at the national level is less meaningful than perhaps looking at a regional level because we have regional epidemics. But right now it is below 1. But all I say is that below 1 is where we want to be. We want it to see it really below 1, and that is sustained in terms of that trajectory. But it is very different in different provinces. So many jurisdictions do have no community transmission or have that epidemic under control. But we're, of course, keeping an eye on Ontario and Quebec, where the two provinces account for about 85% of cases and 94% of the deaths. So looking at their rate of slowing down of the cases and the hospitalization deaths is sort of extremely important as we sort of look at this. But basically, I think with the regional epidemics in mind, which is different, all provinces are showing a decline, basically, in its projections. And so, again, my message is that we are optimistic. We must be very, very cautious because in this next phase, if we ease the measures, and again, modeling will show the different scenarios as to how much of a release in these public health measures one can afford to do. You've seen some of that from British Columbia as well, and the modelers are very much working really hard at this. But really finally is the epidemiology, where if we do see cases reignite, we have to leap on them really, really fast. So that is the premise of the testing and contact tracing.
So in spite of what we heard was or wasn't done, can you confirm to me that Canada is flattening the curve?
Yes, the collective actions of everybody in Canada, including every citizen that heeded public health advice, has brought the initial epidemic wave beginning to control. But one mustn't forget that there is still outbreaks in Ontario and Quebec, in particular certain hotspots. So we haven't quite finished that yet, and we have to be very cautious. But really is the collective action of the whole population. That's how complex this disease is. And so no one single layer of government can do this, but the whole of society has to continue to help.
Dr. Tam, over the weekend, you shared the great news that 50% of the COVID-19 patients in Canada have recovered from the virus. And while that's great news, we aren't quite through this outbreak yet. And I think that you share my concern that as the weather gets nicer and the numbers get lower, more people will be tempted to return to their regular activities. What is your advice to Canadians on how to find a balance between maintaining an effective and a safe practice and also finding ways to take advantage of the nicer weather?
Well, again, definitely listen to your local public health advice because there are differences in activities across Canada, but everybody appreciates that it's important for mental and physical health for people to get outside. The risk of transmission is lower outside. The key transmission settings are indoors and in more crowded settings and where you can't maintain the 2 meters. So I think my message and to all Canadians is that to go out safely. So to go out safely, you can. It still means maintaining that physical distancing, keeping with your household cluster, and begin and observe your hand washing. Don't touch your face. Wear a mask if you can't keep that 2 distance in crowded conditions. All of those layers of protection will allow people to actually get outside and enjoy some of the fresh air. We've had a good discussion at the Special Advisory Committee where they're looking at reopening of different businesses, etc., and looking at, because inside is where the transmission risk is, and they will be very cautious about the numbers of people that can be maintained in an indoor setting while maintaining the public health measures. But going outside is something that should be encouraged, but doing it safely.
Thank you, Mr. Van Bynen. We go now to Mr. Desilets. Monsieur Desilets, 2 minutes and a half, please.
Thank you. I would like to thank all the witnesses who have come here today to inform us. Today is the World Day of Family Physician and care aid workers. So I wanted to use this opportunity to highlight this fact, and I would like to thank them. I have a question for Dr. Tam. You have been answering quite a few questions. I'm sorry, but this question is also for you, Ms. Tam. We are now discussing the idea of an immunity certificate. I would like to hear you about this certificate. Do you agree with that concept at the ethical level?
Yeah, so right now, I think as some of the other experts on this panel said, is that we don't understand enough of the immunology of the virus. If it behaves like other viruses, there will be some immunity if you have antibodies. We just don't know for how long and for how strong. And depending on your local epidemiology, some of these results may, in fact, be false positives or may not have detected the antibody even if you had it. So that's why the Immunity Task Force is extremely important in terms of getting at some of those questions, but also researchers studying the human immune system. So it really, from that perspective, is that not yet. We can't interpret the results of those tests. And so, but you also brought up an important point, which is perhaps there's ethical dimensions to this, where you are now separating people who have at least have an antibody identified and those who do not. And what does that actually mean? Whether there will be stigma attached to one way or the other to people who have been infected or not. So it is a very important point, and one of which that the Immunity Task Force will also be looking at.
Yes, I understand. And if there was to be a second wave, a second strain, would that certificate be valid or not?
So again, it depends on whether the antibody response changes or not, and whether the tests for the antibodies will need to be adapted. But I think, as some of our other experts have said, that there is no current indication of a separate strain. But it's something that absolutely has to be monitored because it's important not just for the antibody test, but for the vaccine development as well. So if the characteristic of the virus changes, it is possible that the test the interpretation of the test or how well the test performs also has to be reevaluated.
Thank you, Mr. Desilets. We go now again to Mr. Davies. Mr. Davies, please go ahead, 2 minutes and a half.
Thank you. Thank you, Mr. Chair. Dr. Tam, on April 28th, Canada's First Ministers issued a joint statement on restarting the economy. And that statement identified the criteria and measures.
Hold your mic up, please.
Sure. Should I start again, Mr. Chair? Thanks. On April 28th, Canada's First Ministers released a joint statement on restarting the economy. That statement identified the criteria and measures that need to be in place in order to take steps to do so, including, quote, sufficient public health capacity is in place to test, trace, isolate, and control the spread of the virus, end quote. Dr. Tam, given that Canada is currently only conducting about 30,000 tests per day, are you confident that all provinces and territories meet that criterion?
Yes, so I think part of it we have to look at the indicators more broadly, but everybody agrees that we need more testing capacity. So that is important. We will, and we are continuing to increase the public health capacity. At the local level, of course, people need to be able to assess whether that capacity on the ground is sufficient to detect any resurgence of cases, so that they can be reassured that if there were cases, this will be detected. So we are updating some national laboratory guidance. We reference that as well, to look at how we broaden the testing to people with milder symptoms, but also looking at some of the other considerations in really lowering the threshold for testing in certain high-risk conditions. And also, I know some provinces are beginning to test more widely in the communities. Those should be part of surveillance systems or pilot studies so that we can get data on what actually happens when you test under those conditions. So I believe everybody...
If I could just drill into that, Dr. Tam, I have very limited time. We know that we've conducted a little over 1 million tests, and we know the city of Wuhan is gearing up to test over 1 million people per day, and that we're well below jurisdictions like Germany and South Korea, who have themselves experienced new infection clusters. So what is keeping us from at such a low rate of testing? Is it a lack of laboratory capacity? Is it a lack of testing kits? Why is Canada stuck at this 30,000 when you yourself, I think, have said that a target should be about 60,000 tests a day? How can we get there?
So based on our scan of the province and territories, there is actually public health laboratory capacity to do 60,000 tests a day. Some provinces are testing below their maximum capacity. They have the capacity for surge reasons, but some of them are not testing because they have very little activity, and they are opening up their society accordingly. But in some areas, particularly where there has been quite a significant amount of activity, I know that jurisdictions are actually trying to increase the amount of testing that they are doing now, particularly in Ontario and Quebec.
Thank you, Mr. Davies.
Thank you.
So that ends our third round of questions. I'd like to thank all the witnesses for sharing with us your time and your great presentations and of course your expertise. Thank you to the committee for sitting here for 3 hours and getting all this information out into the open. And that's it. I declare the meeting closed or adjourned. Thank you.
Thank you.